Thank you so much. Okay, it is my sincere pleasure to introduce Dr. Amy Mitchell Van Steele, who received her BS in Pharmacy in 1992 from Albany College of Pharmacy and her PharmD in 1994 from University of Rhode Island. She completed a pediatric pharmacotherapy residency at Miami Children's Hospital in 1995 and is board certified in pediatric pharmacotherapy. In 2021, she was appointed as fellow to the Pediatric Pharmacy Association. She currently practices as a senior clinical pharmacy specialist for Women and Children's Services in the Bernard and Millie Duker Children's Hospital at Albany Medical Center in Albany, New York. Last year, she received promotion to professor, congratulations, from Albany Medical College. She is a core preceptor for Albany Medical Center's PGY1 pharmacy residency. She teaches medical students and both IPPI and APPI pharmacy students from numerous colleges in our area. Her 30 years at AMC have led to many interesting experiences, including establishing a pediatric unit dosing program for all intermittent and continuous infusion drugs, developing pharmaceutical services for numerous new programs, including congenital heart surgery, palliative care, and metabolic disorders, creating of a standardized pediatric emergency code medication system, pathway, and order set development. Although she focuses most of her energy in the PICU, she can be found throughout all areas of the Children's Hospital and affiliated pediatric clinics. Thank you so much for joining us today. We appreciate your time very much. Whenever you're ready, Amy. And you're muted.
Thank you for that important tip. Thank you so much. I'm glad to be here. As I often tell my students, please speak slowly. I'm an adult learner when it comes to computers. So we're going to talk about adaptability. As you can see, I've kind of done a theme with construction, which if you were in Albany, you'd find that very amusing because we're on the process of ripping down our parking garage. So I've been entertaining myself for the last few weeks just looking at all the heavy machines and how they're managing to make that 3-story building disappear. It's been very entertaining, but it's also kind of a representative of my career in general, because I was hired here to invent pediatric pharmacy. And as you'll see in the presentation, that's kind of why my rotation is a little bit unusual. So first off, I just want to say that this discussion is dedicated to all of us who never quite seem to get as organized as a lot of people want, and that our life is very busy. And of course, it always seems that everything's catching on fire. So I'm hoping to introduce to you guys the typical day that I have, so you can kind of compare whether your life is as crazy as mine. Discuss some of the struggles I have with balancing students with real life, and then share some of the strategies I think that have worked well for me. And of course, share with some of the mistakes I've made, because hopefully you can avoid those. To keep in with our theme, our construction site here is, we are part of the Bernard and Millie Duker Children's Hospital is a hospital within a hospital. So we're 125 beds within a 700 plus bed major institution here in Albany. We're not the only major institution. There's one just 12 blocks down, but we're the major teaching center with the medical school physically attached to our hospital. And so we care for what I've always referred to as the flagpole of New York. I don't know how many of you have studied maps, but New York is shaped like a giant flag. And so the counties we take care of are the counties that border right up on the state that some of you are in. And so we border Vermont, and of course we border the westernmost side of Massachusetts. And so we care for kids in those regions. Vermont, we've kind of territorially divided in half with Dartmouth. So we tend to take the western side of the state and they take the eastern side of the state. But it's not uncommon to have kids born here because mom traveled to deliver the baby from Vermont or Massachusetts. So we're a freestanding children's hospital. We're not a freestanding children's hospital, but we like to, in our mind, think of ourselves as freestanding. And so we have many, many physicians that are just dedicated to children. But it's important to note that I'm grossly outnumbered. Okay, so as you can see, my little numbers on the screen there, we have about 140 physicians. That accounts for all of our attendings and all of our residents. We work closely with, we have a pediatric residency here that's 3 years long. We have about a dozen residents each year. And then we have a med ped program that takes about 4 residents a year that lasts 4 years. Those are our two major programs that we work with. Although we do have individuals come to us from family medicine, emergency medicine, anesthesia. But we have our own little nest of residents that we work on on a regular basis. So basically, there's one of me. I have an order entry partner on any given day. Yeah, I'm grossly outnumbered here. So what are my teaching responsibilities? I do take students from 4 pharmacy schools, so I spread them out through the year. And that's why I don't mean to be, you know, exclusive in the sense that I only offer 1 or 2 slots, but balancing 4 schools, I have to tuck them in a certain times a year so that I don't end up in a position where I'm taking a large number of them at once. So it's not uncommon for me to have perhaps a longitudinal IPPE student throughout that longitudinal experience, have 1 or 2 APPEs from one of the schools, and then in there as well, I have to teach our core rotation for our PGY1. So our PGY1 has just moved to 5 weeks. We have 4 residents, so that means I'm on the hook for 20 weeks a year to teach pediatrics. And as you heard, I'm very excited about the news. I think I'm the first PharmD here to actually get promoted to professor in the med school. So I'm thinking that's a huge accomplishment, but that does mean that I have obligations to them as well. And so I teach every 6 weeks, I teach the 2-hour block on everything you want to know about antibiotics to our med students. So this is kind of how my day looks in a sense. So what team I round with, I'm responsible for 8 different teams. So what team I round with really depends on my learner. I try to gear it toward them because I'm going to be taking care of all those patients anyway. So what team we hang out with that week, I let my learner decide. But we're always, whatever team we're not on, we're their consult service. So we'll be consulting on all the other teams that we're not rounding on. And then as far as the pediatric clinics are concerned, I don't hang out too much with them. I'm fortunate enough that they are within the shadow of the hospital, so they're a quick dash to get to. But we have every specialty clinic except for cardiology within the shadow of the hospital. And I may get drug information questions coming across my email from any of the providers. Our providers work in the clinic setting, and then they also take turns with inpatient service, so they know me fairly well. But there is one clinic that I do have a regular guest star appearance, if you will. We do a longitudinal clinic experience for our PGY1 residents in our pediatric CF clinic. So they meet every Tuesday. So our residents, once they've earned their pharmacy license, will be in that CF clinic. They function as the pharmacist on that team. And then we have what we call EPIC consults. I don't know how many of you are lucky enough that you have EPIC as your medical record, your EHR. We are officially 13 and a half months into owning EPIC. It's been a horror show, as anyone knows who's transitioned to EPIC. It's apparently better than what we had before, but we're still very much in the construction phase, if I can continue to use my analogy. So it's not uncommon for me to get requests on Teams to chime in on a conversation, or in the middle of my busy day to say, if you could just jot down on paper how you want this or that dose, this or that drug dosed for the entire pediatric population, and help us build our EPIC order. So most recently, For example, I've been consulted on epidurals and PCAs. One of the other hats I wear is that I'm the programmer for our analgesic pump and our Medfusion syringe pump. So I am the in-house also expert on PCA and epidurals for all age groups because I am the pump programmer. So I'll do that. And then being the epic or the pediatric expert beyond epic, the pediatric expert, um, our children's hospital now is the only one that truly cares for children in any kind of complex way for our entire region. So as other hospitals need thoughts on how do they handle this or that in their NICUs, because we do have a few NICUs that are still in our area, it's not uncommon for them to call me on those kind of things as well. And one day I woke up and we were part of the Albany Med Health System. So one of my other hats is that I'm the pediatric expert now for our health system. So that being said, that's typical day. So my students, you never have to worry about finding drug information questions. They just land all over my desk on a regular basis, some of which can be super fascinating for them. One of the drug information questions we got most recently from our clinic was, what should I do? My student has, or my patient has contacted me frantic, wants to know if the topiramate capsule their child is taking results in little particles ending up in their stool. So that, I think, spent my student several hours, but that was an interesting side question. So anyway, we get lots of different things going on. But I often bring up the concept of micro versus macro pharmacy because, as I mentioned briefly, the purpose of me being hired at Albany Medical Center, and it has been the only job I've ever had, has been to create from scratch pediatric pharmacy here. So I have done a lot of macro pharmacy, which means I've had to create processes, create everything. So when I first came here, we did not make any medications patient specific for the children's hospital. So it was my responsibility to literally create all of what is now our IV room process where we make medications for kids. We also had a big undertaking in doing our oral unit dosing program and our non-sterile compounding. So a lot of things going on. That's why people always come to me for process type stuff. And I notice my students do a lot of process management type projects because it's an ongoing construction here and building what we our whole pediatric pharmacy practice here. So these projects, they just find me. I usually have at least 10 of them going at a time, again, because of all my different areas. And so those I often will weave into, I'll weave them in as assignments for my students. So fortunately, there are some, each of the pharmacy schools have slightly different workbooks or checklists, if you will, which keeps me in a constant state of confusion, constantly asking my students, have we done everything we're supposed to, or are you going to get in trouble? So the macro pharmacy, it's always fun. We do a whole bunch of those. Every single one of them are always considered optional. So I try to be very conscientious that we also make sure we have in what I call the micro pharmacy tasks. Those are the tasks that are specific related to exact patients. So we do round on our patients. I insist that we do our very best, unless it's too chaotic, to write daily notes on all of our patients, discussing their medication management. So that gives the students here a chance to kind of do that whole SOAP note and case presentation concept. So what is a typical day like here? Well, despite the advice that says do not allow your email to dictate your day, I have never found that that has worked for me. So I like to kind of know what I'm in for the day. So that is how I started. What kind of email am I getting and what kind of emergency or fire am I putting out for today? And so we kind of sort through the chaos and we prioritize it. So my student kind of becomes my right-hand man or woman, if you will. And so we check out my emails. I'm like, oh, well, today, it might be today we have a critically ill hospice patient that needs has a special need with us getting them a unique concentration of an opioid. It might be that this or that order set has been recently discovered as not functional and therefore a patient safety risk. So we'll have to sort through that today. So anyways, we sort out what the email has brought us as far as crises, and then we get together and we go on rounds. So my students always come in earlier than me. I warn them that I do not leave my house until the sun is already awake and I have an hour commute. So I figure as long as you're honest with them, they can kind of relate to the fact that you're not going to quite fit into, the round peg, so to speak. So my students usually arrive before me and they're preparing for their rounds. And then they meet up with me about a half hour before rounds and we go over their urgent questions. Now, I put eat on the schedule because even though I'm the kind of gal that tends to eat while I'm doing emails and stuff, I don't like to miss any meals. So I always warn my students that their stomach is their problem and they should never consider themselves rude if they have to remind me that I forgot to remind them of lunch because I dragged them to some meeting or what have you. And I've also discovered that it's also an opportunity for us to have time apart, the whole heart grows fonder thing. So I dismiss them for lunch so that I can have a few moments to myself, catch up on maybe some errands I have to do. When you're a gal who works 8:30 to 5:30, nothing you ever need in your real life is open once work is done. So sometimes I have to make phone calls or do errands. And we have a lot of meetings and projects that tends to occupy us through the afternoon. And of course, chaos is hitting us on a regular basis. So, and then we teach. I do try to make sure that we discuss topics and we discuss topics on as basic a level as the student needs to hear it, and that they walk away thoroughly understanding the disease state and how it's taking care of their patients. So topic discussions kind of range for what we are going to be able to see. And of course, upon exit, depending on the day, it depends on how fast I literally run to the car before someone else needs me for something. So what are the kind of struggles that I get? I would say lack of time. I mean, you guys probably guessed that there's a lack of time for everything. I try to do my best to do twofers. Living in the moment means you can't always plan the next move. And I warn my students that I can't always predict what we're going to do tomorrow. We do end the day, as you'll hear in a few minutes, that we do sort out what do we think we're going to be doing tomorrow. And then, sometimes there are some crazy things that go on and you really wish you could scream, but of course that's not really good behavior in front of a student. You're trying to role model. So, you take a bathroom break right about then. But there are also times where, depending on what's going on, that has ended up being an opportunity to role model how to interact with other team members who maybe aren't as kind and polite as you would like them to be that day. And then I'm balancing the needs of my student over the needs of my patients. I have so many patients at any given time, I think I'm probably numb to it. But I do try to remember what it is my student needs from me. And I gear kind of our projects and whatever our learning opportunities toward what they want to learn. Because again, there's plenty to go around. I think my other challenge is balancing the needs for everyone, like trying to keep track of what everyone else needs. And, as many of you probably have as well, there's the issue that I myself tend to get lost kind of in the shuffle. Having different levels of learner within the same rotation, I've even had that as an issue, even when the two students are both technically on the same rotation. As you know, not every IPPY or every APPY student is the same. So just getting a feel for what they know. My topic discussions tend to be conversational. So as you've probably heard from some of my I've only had a couple, but some of my former IPPY students, I just pull them in on the conversation. First, I assess, did you get this in school yet? I don't want to overwhelm you. And if they'll say, yeah, I had that last week, then, well, okay, the ante's up. You better know more than we do because you just got it in school. But I do try to account for the fact, okay, you haven't heard this yet in school, then listen closer, because we're gonna sort it through and explain it to you. And I have had students say that seeing it in real life and hearing us talk about it tends to finally have that last click, and they finally get disease states that didn't maybe make a whole lot of sense before. And then, I've just said the different levels of the learner. Let's see. And then, unfortunately, if they're really struggling, it is quite a challenge to figure out how to get more help from them when we're already kind of out of time. Um, so there is concerns that the students' assignments take up a lot of time, and then my projects take a back seat because let's face it, we're all about having to get our work done, and taking on students, no matter how you try to slice and dice it, ends up being additional work. Um, so what I've balanced again is my projects become theirs. This is how we do it. Like everything is twofer. So you kind of get a feel for what your student is capable of. I'll talk about in a few minutes how I actually have a form that I have them fill out, and I have them reveal for me what they're, and I ask them as well, what is your life goal? What do you want to do when you graduate? And I try to aim projects that match their career goals. And so they tend to be far more enthusiastic, more engaged in the project. And some of it I can give independently, and some of it, we'll work on literally side by side. So that varies because, as projects are concluded, well, we don't have that in our list of things to do anymore. So it's different for every student, every rotation. Um, and then sometimes we do like life lessons. Okay, so it depends on the season. So, and it depends on what the student's up to. So for example, the student I had in January is all pumped up, if not frantic, over the fact that they're about to do residency interviews. And so maybe we take a break and sort through their CV together. Maybe I quiz them and give them a few practice questions. All right, here's some interview questions. This is what we use to test our candidates when we interview. Maybe I give them we walk through a case. Our interview style here for our PGY1s is they have to do a case for us. We give them 48 hours notice and they have to present a case. So that's how we assess their clinical thinking skills. And so if I find my student is a little distracted because they're very worried they have something similar coming up, then that's what we'll review. Sometimes they reveal to me that they have to do a presentation for their interview. And so we'll take a topic, we'll take a case, and we'll do the whole, you're going to build with me your presentation. So that way you can be the best candidate you can be for your interviews. And then sometimes we're talking about job hunting. Again, it depends on the time of year and what's going on with them. So planning our next move. Okay, we try to do that. Unfortunately, we have to do that almost twice a day. Like when we first come in to sort out the chaos we get introduced with. And we try to do that at the end of the day. So again, I pull them right in with me. And then the student's really good about being my peripheral brain and reminding me of all the projects that I promised to do and my deadlines. So they're really good about don't you remember you have to do such and such today? Or remember we went to that meeting last week and they really want you to do X for their newsletter by Friday. So having my student with me, they feel that they are fully functional on the rotation, as well as, they help me remember all sorts of stuff. We're constantly writing lists. They get lost on my desk, but we try to constantly write lists just to keep organized as to where we are. And like I said, at the end of the day, we kind of sort through, all right, what things are still here? What are we going to have time for tomorrow around the meetings? And I think that really that kind of gives them a little role play as to how to prioritize and set deadlines and all of that. But really, the reality is it keeps me remembering what we need to do and keeps me sane. But it's a pretty good way to role model for the student. And we just walk in knowing that our email is going to have who knows what disasters. I'm always leery when I have a day that doesn't have some kind of crazy email in it. And then we may divide and conquer. So I may have two meetings in that exact same hour. And so I asked the student, well, which one do you find more exciting to go to? Like, I'll let you be the tiebreaker as to which one we attend. Um, because I got to go to one of them. So which one do you think we should go to? Sometimes if it's far enough in the rotation, I may send the student to represent me at one meeting while I go to another. We have been as crazy as going on two virtual meetings. They go on a laptop and I go on my main one, and we literally listen to two meetings simultaneously. That's a bit chaotic. I wouldn't necessarily recommend that. And then sometimes we plan on separate work times. That's been helpful as well. So my students kind of start to read in and say, look, this is something really important you need to focus on. I'm going to go down stairs. So my office is on the 6th floor. On the 1st floor, we have a general pharmacy student workroom that's right near the pharmacy residence. So we may plan on the afternoon, like, all right, I'm going to go down to lunch. I'm going to work in the student room for a couple hours. We'll reconvene at this hour and regroup for what we're going to do tomorrow. So it's nice that the students also start to plan their free time independently and will review with me what they're going to do. And so that's really helpful too, because that means I do get a little time to myself. And we do try to keep each other accountable for whatever big deadlines are happening. They're also really good at reminding me if not the emails. I know Dom sends out emails as well, but just reminding me, like, don't forget we got our midway point, like, to review. So they're really good about that. So what about taking days off? I'm one of those people that gets so much vacation. I just discovered recently that I've stopped accruing vacation because I have too much. Because I don't like to take days off when I have learners, because we can't learn and teach if we're not in the same place. So I try not to take days off when they're here. But if I have to, I do have things that they do. But we usually sit down and look at a calendar, and they tell me what days they need to be free, whether they have to go to a friend's wedding or they got an interview or whatever their dealio is. But so I say, oh, you need Friday off? I'll take Friday off. So this always works out. They're never usually sad about telling me they need a day off, because I usually just take it too. But when I do have to take time off, um, uh, because I'm away on vacation, or maybe I have to go on a conference. One year when I had to go on a conference, I had a student. It was a virtual conference, and we actually went to the conference together in my office. So that was kind of unique. But when I have a day off, there's no account for it, because I really can't work too many days in a row. I usually have to give them assignments. So we'll talk very carefully about what they're going to do. And I'm very honest with them to say, I got to keep you busy enough to justify at least 8 hours of your life have been spent on something important. So we sometimes it's, oh, you said you really wanted to learn how to write lectures. I guess that's today. So you're going to do all your investigation and you're going to work on your lecture. And when I come back, I want to see at least a preliminary draft. So I try to be very specific with them. They're usually pretty good about giving me feedback, like, I'd like to do X, Y, and Z. This is also where I've taken some of the tips that I've learned from one of your topics too, which is for preceptors, which is, don't forget your students will have to be studying for the NAPLEX. So sometimes I have them do NAPLEX review if I can't think of anything too bulky or have any assignments for them for their day off. Part of it may be, okay, I want you to review X chapters in your NAPLEX review, and then we can talk about them when you get back. So again, what do I do about my personal space? I have, I think, a pretty awesome office. It's taken me 20 years, but I have earned my very own window, of which many people are jealous. And I have a big L desk. So my students do get a corner of my desk. So they have their own chair. In fact, they face the window. So they got a pretty posh place to sit at. And then, like I said, I do send them to our student room when in the afternoon or early in the morning when I'm not here yet. They'll prepare for their patients, and then they'll come up to my office and meet me. So that's kind of how we do it. There used to be times where literally my students spend every second with me, every moment of my day in my space, and we'd have to ask permission of each other to go to the bathroom. That became a little too intense. So I have learned to back off and give ourselves like literally separate spaces and have them go off for lunch. So I'm not saying I'm Catholic necessarily because like I know Catholics don't own the market on guilt, but um I do have a lot of guilt about many things. Like, am I doing enough for all my patients? Am I doing enough for all my students? Have I met all the obligations of just the things I'm supposed to do for my job and everything? Um, so yeah, I get weighed down by guilt, but I think by having the student literally merged into my world and seeing what I'm up against, they're far more understanding and more realistic of what I'm actually dealing with. And so um, I kind of deal with my guilt by just constantly asking them, hey, did we do all the stuff on your checklist? Wait the checklist. I can't remember what your school checklist says. Like, let's make sure that we're not in trouble there. And so they laugh at me. They've printed off checklists for me just so that I have them to look at and I have them sitting at my desk. Um, Feeling outnumbered. Well, I already told you that there's like 400 nurses and like 100 and some providers. And then there's me and my order entry partner. So I do tend to if I have more than one student, sometimes I'll have them do um, different pieces of the same project, and then we can bring it together. Our topic discussions are always done joint, and again, it tends to be conversational. So I'll have the students maybe take turns being the main person to present the case, present the topic, and lead the conversation. Um, it's often led by rank. So if I have a resident, the resident may be the one that leads it, and then the API student jumps in or the IPI student jumps in. But I really try to make sure that we're all included in the conversation and that all of us feel comfortable asking questions and throwing in comments or what have you. I often tell the students as well that don't feel that if I have things to say, it's because you didn't do a good enough job, but that A, I'm a chatterbox, and B, my job is to teach you something. So leave a little something left out that I can contribute to the conversation because otherwise I'll feel like I didn't in any way teach you today. So um, I often have them read on a topic and then I ask some very focused questions to make sure that their understanding is fairly thorough. And then I'll add in what I call pearls. All right, you didn't read this in the guidelines. I'm going to tell you some practical real life things that happen when we take care of this disease. Sometimes, like with asthma, it involves reviewing why we structured our asthma pathway the way we did. And then it kind of clicks as to how we put the guidelines in motion. So anyway, this brings up to what Dom really wanted me to talk about, all of this to lead to the real topic. So I had a couple of IPI students, and as I say, unfortunately, people have to understand that I get constantly confused because every school is slightly different as far as what they want. And so the IPI students, I usually had taken IPI students where they have like 40 hours with you, flashbang, they see what's going on, and then they go. So the fact that Western New England had a longitudinal IPI student was kind of a new experience for me. Um, and my first year we were still coming out of COVID. So it worked out well that I'd gotten my COVID vaccine and like many people felt really, really ill. So I just told my IPI student at the time, I am not going to move today. So today is a good day to work through your workbook because I'm not going to feel well enough to move. So she was very understanding, and we literally worked through the workbook. The workbook I had at the time was for an institutional rotation. So being a macro pharmacy kind of person, I could talk through all the parts. I knew about our code, what is in our code drawers, because I had to create all that for pediatrics. But it was very kind of clunky. So at that point, I had one more student, and I started realizing that I wish I had my own workbook that reflected acute care. Okay. So I reached out to all of our schools, and I said, would you guys mind if I started putting together a book, a workbook for these IPPY students that better match what I was going to do, a mix of the micro and the macro. And so that's what we did. And so this is just kind of a picture of the cover page of the book we put together. So talking about transitioning from student to resident to clinical pharmacist, this is something I try to emphasize to all level learners. And this is the part where I think the real rub of it is, and we talk all the time about you're looking to become a PGY1 resident, you're going to have to make a big leap. And the big leap is the fact that your cases that we're talking about, these soap notes you're writing up, these people are real. And the moment your patients become actual people, you've already begun the transition of becoming your full professional. So we get too much caught in the process of how do I write my soap note? How do I do this? And so we do our best to make sure that our patients are also real people. It's surprisingly when you're dealing with peds how my students often get caught up on their social problems. And so we do end up talking a fair amount about ethics. And I just do my best to kind of give them perspectives that if we have a patient whose mother has not been visiting, it may not mean that she doesn't care about her child, but simply that this child is one of 9, and she's got 8 more at home, because that happens also. So I figure that's part of my role, is to also make these patients real. And so if I have students who, for example, are going to retail, we'll really push the transitions of care, and we'll work on what does it mean for the mom to have to give all these meds once they're at their house. So with that, I'm at the end, and I'm ready for any of your comments or questions.
Amy, wondering what feedback you generally get from students. What are their favorite things to do when you have them on an epi?
Well, my second IPPY student was the one who inspired the workbook, because there's one comment that I remember, and there's why I really remember the comments, because years ago I made this vow to myself that I was never going to read any student feedback, because I think all of us get some student that's annoyed about their grade and they say terrible things in their feedback. So I stopped reading it. But to get promoted to professor, we have to hand in an education portfolio. So it forced me to literally type out and summarize every comment I've ever gotten from any learner in the last 8 years. So I say I did have to talk myself down when I realized I was distressed that I only got 80% vote for the top thing of whatever it is I was reviewing, because you get so caught up and say, what? I didn't get a perfect grade from the student? Like, I've got to be a failure. But I say most of it is they're pretty excited to just see so much. And I don't have to put on a show. This is real life here. We just have so much happening and going on. So they get exposed to a lot of things. My students will pride themselves in that by the time they finish my rotation, they can whip up their very own opioid wean like that, because we have to set them up for the kids, and write calendars out for them and stuff. So they really like writing the calendars for the parents, because they feel they've really truly connected with the kids. So I'd say that's probably the most thing, is that they really enjoy the variety. And a lot of things that they've learned in school become very real to them because we talk about the patients and, oh, so you learn about diabetes. Do you understand X, Y, and Z? No, I thought I did. I have no idea. And then they see a real patient. We talk them through it, and then it finally clicks.
And sure, over the years, you may have encountered a student or two who is not doing well, um, or lacks the knowledge you think they should have. What do you do in those cases?
Um, well, I have had learners, not necessarily students, but I have had learners that, you start to catch on that they're not engaged in your rotation, that you're starting to pick up that they're going through the motions. And so I think I tend to be a fairly direct person and I call them out. I think I've said, look, I'm noticing you're not really engaged. Is there something that's stressing you at home? And I have had residents say, I'm stressed out about this and that. I'm like, okay, that I can fix for you. Now that you've revealed you're worrying about X, I can do this for you. Like, is it in my job description as your pediatric preceptor to find you a doctor? No. But if you're stressing that this you need a primary care doctor and you don't know where to look for one, let us take a few minutes. We will find one. We will get you an appointment. Now you no longer have to worry about this and you can return to my rotation intact. So sometimes I will ask them if there's something bothering them and if it's something I can help with. Like if they say no, I don't want to talk about it, that's their business. We're done. But I do try to, if I catch on they're not engaged, that could, I usually see if there's something distracting them versus that they just aren't able to learn. I will ask them things like, are you finding this is really confusing? Is the pace a little too quick? You're like, yeah, I'm having trouble taking this in. Well, then we'll slow it down, and we'll review stuff. I've been fairly lucky, but I haven't had too many students who really seem to get too lost.
Thank you. It seems like you really tailor your rotations to the students or
Yes,
each
I
individual
try
student.
to. I think that's kept me from, so students who might not have had maybe the most optimal grades,
Mhm.
or who perhaps on paper have struggled in previous rotations. I think because I just pulled them into my world, and we just, okay, remember this is a marathon, pace your steps, we just jump in and I haven't, students who would have perhaps given other people problems, either I'm just not picking up that they're a problem student because they're doing what I'm looking for them to do. I usually am just thrilled to pieces that they want to learn, and that they don't have a negative attitude. So, um, yeah, I think I've been lucky because I keep asking myself, what am I going to do when I have someone who really struggles to learn? We did have a resident a few years ago who confessed that he had trouble with reading comprehension. Um, and so that made it hard if you give him all, reading assignments, he has to read it over and over and it takes things longer. I did research how to talk, just, how to teach and interact with someone with that kind of learning disorder. And so I feel like I tried to adapt best I could to him and what he needed. Once he confessed that that was one of his issues, I was able to do something about it.
Thank you.
Mhm.
What's the max number of learners that you'll take on rotation at one time? And do you take any blocks off for yourself?
Um, well, every year I attempt to take the summer off, and every year the boss tells me you have to take a PGY1 in August. But I do try to spread them out. At most, I try to just do a triple layer where I may have a resident, an appy, and an IPPY. But my IPPYs fortunately tend to be like once a week. So I really ought to get the triple layer, one out of the 5 days. I find if I have a student along with the resident, our PGY1 residents like immediately start like fostering them. Sometimes I have to remind the resident, no, no, You're not their preceptor. I am. They get a little too enthusiastic, but I find having a student the same time as a resident works out pretty well. It's less intimidating, I think, to do a topic discussion with just me. They've got another person that they can kind of also teach. But I have had really a crazy roller coaster. I think at one point I had a resident, 2 appies, and an ippy. So I was definitely on the brink of insanity there. That was too much, which is why I have to be very careful. Dom and other friends like him, if I put that I want 2 students, they're more than eager to give them to me. So that's why I'm very, very cautious of myself, and I try to only ask for 1 in a specific module so that I can spread them out. But that's, yeah, that's what I try to do. And when I'm teaching med students, I just pull in whatever learners I have with me. They have to go to the lecture too.
Clearly, you're doing the work of more than one person. Have you ever considered asking for help for yourself? I mean, clearly you enjoy what you do as well.
This be funny. I was, the other day I was calculating it. I figure I've saved the hospital at least $2.5 million. Because 25 years of my career, I've done the work of 2 to 3 people. And if they had paid pharmacists, my gosh, we've piled up millions and like good vibes here. No, we've talked about it numerous times, getting me someone to work with. I had someone originally. Funding here didn't allow me to have someone for a really long time. I had someone briefly a few years ago, and we just had conversation this week that okay, seriously, people, I'm gonna need to be fitted for one of those white jackets soon if you guys don't find somebody. So oh yes, this is not, yeah, we've had this conversation. I try when I can to have other people take on things.
Thank you.
Thank you.
Well, Amy, thank you so much. I think this will be recorded and sent out. It's great to see some of our preceptors here. Thank you so much. And we look forward to seeing you again next time.
Fantastic. I hope I've given you some inspiration that you can teach in the chaos. Have a wonderful day, everybody.